All right, let's get started. So I'm Michael Warren. I'm a PhD student, first year PhD student at the Guns. I'd like to welcome Dr. Anna Stewart Ibarra, who's visiting us from SUNY Upstate Medical University, or Medical College. Anna is a research scientist and Latin America research coordinator at the Center for Global Health and Translational Science at SUNY Upstate Medical Center. She's also a research assistant professor in the Department of Microbiology there. So Anna is going to be talking a little bit about some of her research focusing on understanding the environmental and socio-political drivers of dengue fever transmission in coastal Ecuador, where dengue is hyper-endemic. Make sure to get that word right. So Anna received her PhD in ecology from SUNY ESF. She has been up here before. And I think she's worked on your committee, was a UVM professor, correct, for your PhD?
No, it's a battle of the
Okay.
Perfect.
Perfect. So prior to that, she did an MPA at Syracuse, and she was a recipient of a Fulbright Fellowship in Ecuador, as well as an Emerging Public Policy Leader Award from the American Institute of Biological Sciences, as well as the award for Outstanding Student Research in Ecology from the Ecological Society of America, and an NSF STEM Fellowship recipient. So with that,
Thank you.
let's get started.
What's our time?
We've got till 1, so you've got about 55 minutes and including time for questions.
Thanks for coming, and thank you for the invitation. Thanks to Deidre. I know she's not here, but she's been lovely to work with and coordinated all my logistics and the visit. So please send my thanks to her when you see her next. Thank you for the lovely presentation. I am a research scientist and research assistant professor at SUNY Upstate Medical University. So I'm going to be talking about pretty much the last 8 years of research that we've been doing down in Ecuador on dengue fever, and how this has all culminated in our ongoing dengue surveillance projects that I'm working with at SUNY Upstate Medical University. So just a quick survey of the audience. What are people's backgrounds in the room? Just generally? Ecology, modeling,
Journalists.
economics, a little bit of everything?
Economy.
Okay, so please ask questions, and if I say something that is kind of totally out there, don't hesitate to let me know. Oh, and I'm Ecuadorian, and I'm a US citizen, so I'm a dual citizen, so I have a lot of close connections to Ecuador, and I spend about half my time down there right now. So half the time in Syracuse, half the time in Ecuador, where I have my research team. Okay, so emerging infectious diseases. They're here to stay, right? Ebola is big in the news right now. We have new diseases that were never before documented, like Ebola and HIV. We have diseases like dengue fever, Lyme disease, West Nile, which we have in this area, right? Which are diseases that are not new, but are now moving into new areas. And we have diseases like malaria, tuberculosis, and influenza that are evolving and developing resistance, like multi-drug resistant tuberculosis. So all of these different forms of novel diseases can be considered emerging infectious diseases. And this is not a trend that will likely slow down anytime soon. We know there were over 300 emerging infectious disease events identified since 1940. And 60% of these were zoonotic diseases, or diseases that move between animals to humans. And 23% of them were vector-borne diseases, or diseases transmitted by arthropods, mosquitoes, ticks. And if we go back a minute, you can see that many of these diseases, especially those that are vector-borne diseases like Lyme disease, dengue fever, and West Nile, malaria, these are diseases that we consider to be climate-sensitive or water-sensitive diseases. And more, this WHO, the World Health Organization, is drawing attention to the need for research and public health interventions that link climate and health. Although I would say this is still very much an emerging area, and we're just starting to get the conversation going. So for those water or climate-sensitive diseases, you can think about different kinds of information that we could use to develop an early warning system. So this is traditionally where we've stayed, down at this corner, right? Disease surveillance. That's classical public health. You count the number of cases that come into the clinic, that goes into some database. These days, maybe it's electronic. Maybe in some places, other places, it might take a week or two before that information actually gets to the person who would go out and spray for mosquitoes, for example. So we have disease surveillance, and with disease surveillance, you might have a response time of a few days, maybe a few weeks if you're lucky, in terms of, by the time you start to detect the cases, how long until we reach the epidemic. Mosquito surveillance, we gain a little bit of time. So if we know that the mosquitoes start to go up and a few weeks later the cases through mosquito surveillance or vector surveillance, we might gain some time. We can monitor the climate, so something as simple as rain gauges, monitoring the temperature and the rainfall. If we know that there's a relationship between climate and the disease, then we gain a little bit of time, maybe a month, depending on the disease, depending on the local ecology. With seasonal climate forecasts, we can usually predict 3 months out what the climate will be. But we notice as we go up, right, the uncertainty increases. This is the key difficulty when we're working with decision makers and people who have to decide how you want to spend your tax dollars to prevent an epidemic. Uncertainty increases, but we gain more lead time. And lastly, out here, we're El Nino Southern Oscillation forecasts, or sea surface temperature data that we use to then forecast what will happen with local climate. And so linking these different kinds of climate and public health data is really sort of the challenge here. And just getting that conversation going has been probably 90% of what my work is dedicated to at the end of the day. But thinking about how we can demonstrate these linkages through statistical models, through field studies, through dynamic modeling, that's also some of the work that my team is doing now. And also strengthening surveillance at all levels, because without good data, without these reliable streams of information coming in to an early warning system, your predictions aren't any good either, right? You could have this beautiful model that works in theory, and if you go to the field and in the real world, there's no mosquito surveillance, the cases, or there's a 2-week lag, and when the time the cases are detected until it actually gets to the system, then translating your beautiful, theoretical ecology model into the real world, it doesn't always work. There has to be that linkage with working with practitioners, and that's why these partnerships with institutions that I'll talk about a little bit it's really critical. Just to mention also, underlying all of this, we have to have an understanding of what is the local social-ecological system and what are the local vulnerabilities. We might be able to predict that there will be increased likelihood of dengue in a certain region in 2 months from now, but then within that region we need to understand what are the populations that are more vulnerable and what are the factors that influence their ability to respond to some sort of public health message or warning. And the institutional abilities also. This is just a really quick example. This is data, dengue data on the bottom from Ecuador. These are just cases per week, and on the top it's temperature. So this is over from 2005 to 2008. So normally, when would we intervene if we were just using case data? Maybe here, if we have kind of sensitive disease surveillance system, we might see that the cases are starting to go up. And so if we want to, in this given year, we might start to intervene here. If we have temperature data, maybe we could intervene there, right? We start seeing that the temperature's going up. We know that there's this demonstrated relationship. Maybe it's a seasonal cycle. Maybe these are interannual cycles. And then if we have El Nino Southern Oscillation data, and we know that there's a relationship, we might gain another few months of lead time. If we see that the sea surface temperatures are going up, and in this region in particular, that's associated with temperature and disease, these are all the linkages that we have to make, then we can gain another few months of lead time. This is really important for public health decision makers and government people who need to make decisions about how to allocate resources, right? It's really hard to allocate resources if you have 1 week before the epidemic happens. If you have a few months of planning and lead time, we're more likely to be able to make effective decisions. Okay, so very briefly, this is what informs my approach to research. I think you've already gathered this, but my work is focused using a social-ecological systems approach to research design and analysis. So looking at social and environmental drivers in the system, looking at linkages, and we work with a very interdisciplinary team with researchers from the US and Ecuador. And we have very strong interinstitutional partnerships. This is really fundamental to the work that we do. So I'm a visiting researcher with the National Institute of Meteorology and Hydrology in Ecuador and with the Ministry of Health, and have been working closely with them for a long time. And just having these strong institutional partnerships, government support is really critical. So the work that we're doing, as I mentioned, also is to strengthen the surveillance systems that are on the ground. And we use modeling as the way that we bring together all of this data to predict disease risk. And another part of our research program that's critical to me is the ongoing training for researchers, practitioners, and students.
Wait, can you say who that is?
That is H.T. Odom, Howard Odom. So, yeah, I did my PhD at Charlie Hall, so this is 2 degrees of separation. It's my academic grandfather. And this gobbledygook is a systems diagram, which probably many of you have seen. So we've all had to suffer through our systems diagrams. Spent many years in my PhD with Charlie, like, give me a systems diagram. Every time we met, where's my systems diagram? So this is where I work. This is the research site where I did my PhD work and where our ongoing surveillance studies are, where we're developing a long-term research platform here. This is a city called Machala, Ecuador. It's in the southern part of the city. For those who are not familiar with Ecuador, it's located on the equator, sandwiched between Colombia and Peru. It's a very small country, but it's one of the most biodiverse places in the world. It's a really incredible place to work. So on the Pacific coast, the whole coast used to be mangroves. Much of it has been converted to shrimp farm. This area here is Guayaquil, the biggest city in the country, and that's the biggest estuary on the Pacific coast of South America. Down the center of the country run the Andes Mountains, and on the right side, on the eastern side, is the Amazon Basin. So the area that I work in is the southern coastal region, about an hour and a half from the Peruvian border. These are all shrimp farms and banana plantations, so very rich agricultural area. It's an important port city, a city of about 250,000 people. And it's hyper-endemic for dengue, as we said in my introduction. So lots of dengue co-circulating there, and I'll give a little bit more background on
What distinguishes hyper-endemic from endemic?
Hyper-endemic, year-round transmission, I think, that's like elevated levels. We can have outbreaks in outside of what you think of the seasonal curve. Yeah. Lots of dengue. So just a little bit of background, because I know there's no dengue here right now. Dengue is now one of the most important public health issues in the Americas. It is the most widely distributed vector-borne disease, present in 40 out of 44 countries and territories in the Americas. All 4 serotypes of the virus, there's 4 different sort of strains, they co-circulate through the Americas. And the burden of disease in the Americas is comparable to malaria. And this is a graph showing the incidence of dengue from the 1980s to 2007. So dengue was actually endemic throughout the Americas before the 1980s, but it was eradicated through very effective DDT campaigns. Basically, yay, dengue is gone, stop doing vector control. 2 decades later, guess what? We have now even more dengue than we ever had, largely because now we have all these 4 serotypes co-circulating, which you didn't see before. Yeah.
What do you mean by burden of disease?
So this is the WHO calculates the burden of disease using disability-adjusted life years, or DALYs. So that's using DALYs.
So the burden of dengue is comparable
the
to
morbidity and mortalities combined.
Comparable to malaria in the Americas.
In the Americas, correct, yeah. But for example, where I work in Ecuador, it's much more than malaria. So malaria has been effectively controlled largely because we've invested a lot in malaria control, right? And so there's like this lag where dengue's come on the scene and yet the resources haven't yet been mobilized to deal with dengue, and the infrastructure and sort of how we do vector control the model hasn't shifted yet, and dengue is very different than malaria, and so there's some issues.
And do you get immune to each serotype when you get it?
Good question. That's on my next slide. Just very quickly to point out that these issues of dengue and chikungunya, which is right now this tremendous epidemic. I was just in the Dominican Republic last week, and everyone wanted to talk about chikungunya. Practically every other person I spoke to had it. People showed me they still had evidence of swelling in their joints months later. Chikungunya is another virus transmitted by the same mosquito as dengue, which I'll explain in the next slide. But we have chick in Florida. We have dengue in Florida. There was the first case of dengue reported on Long Island this last year. So it's very much an issue in the US. These are not just issues for countries on the equator. Quick little background on dengue. So multiple infections are possible. If you live in an area like Ecuador where all 4 serotypes co-circulate, you have infection. So if you're infected to one serotype, in theory you have lifelong immunity, although there is some evidence coming out that might not be true. But generally so if you're infected, you have a period of waning immunity when you are immune to all 4 serotypes that are co-circulating, and then that disappears and you're only immune to that one serotype you were exposed to, and you can then have secondary infections from the other serotypes. So for example, this year, and often there's one serotype that dominates in the region, but this year we're analyzing the data now, and where we're working, at least 3, if not 4 of the serotypes are co-circulating, which is a really, really bad situation, in coastal Ecuador. And especially because we're going into an El Nino year, it's quite troublesome. Anyways, dengue, present in over 100 countries. As I said, there's 4 dengue serotypes. They're transmitted by our friend, the female Aedes aegypti mosquito, which importantly is an urban mosquito that breeds in containers in and around the household. That's critical to understand. Very different from malaria, transmitted by anopheline mosquitoes that tend to be more in rural areas. They breed in pools and standing water, but not so much in these things. So dengue, and how you think about how you would control and how you would go in and eradicate the mosquito, is very, very different than malaria, right? And so understanding the ecology of the mosquitoes is critical.
Is the mosquito introduced?
Yes, but a long time ago. So I think originally dengue is thought to have come out of parts of Africa where the vector and the mosquito circulated with primate populations, but that was like several thousand years ago. And then it was in Asia, and then after World War II, it spread into the region even more so. But there were outbreaks of dengue in Philadelphia in the 1700s also. So the mosquito's been here for a while, but it's not native, but it's been here for a while. Yeah. And Aedes albopictus is a secondary vector, which we don't have in Ecuador, but there is Aedes albopictus throughout much of the US. And that's a vector also for chikungunya, and that's a more rural vector. Aedes aegypti tends to be the primary vector. This is really important also. So in these areas where you have multiple serotypes co-circulating, you have greater risk of severe dengue hemorrhagic fever, shock syndrome during secondary infections. And there is no vaccine or medical treatment available. You can treat with liquids, paracetamol, that kind of thing, but there's no vaccine currently available, although there are more than 20 different vaccine candidates right now in different stages of clinical trials. At Upstate, we have 2 different clinical trials for dengue vaccines that are ongoing. And so there is promise. This is similar to yellow fever in that it's a flavivirus, so we have successfully created vaccines for flaviviruses before. What makes this more complicated is that there are 4 serotypes. So we need to have a tetravalent vaccine, which is really complicated. And so there are Sanofi is really the lead right now globally for dengue vaccine trials. And if you look at some of the recent papers that come out, they'll say, well, the vaccine protected against dengue 1 and 2, but not against dengue 3, and so that's the challenge right now, is how do we get sufficient level of protection across these 4 serotypes. So until we have a vaccine, and probably even after we have a vaccine, vector control is really the primary way that we prevent and reduce an epidemic even when it's happening. So briefly, the transmission cycle for dengue. You have the first person over on the left who is viremic, so the virus is circulating in their blood, they're infectious. The mosquito, Aedes aegypti female, comes and bites that person, feeds. There's the extrinsic incubation period, which is the period when the virus is replicating outside of the person, so extrinsic, inside of the mosquito. There's a few days go by, the virus replicates in the mosquito. That same mosquito then goes and feeds on that person's husband or wife. And then there's a period of intrinsic incubation, so incubation of the virus replicating inside the person. After several days, the person is then symptomatic and is then able to transmit the disease also, so during viremia.
What's the range of a mosquito?
The flight range?
Yeah, I mean, how wide of an area does a mosquito vary over?
Depends on
This species.
These, yeah. So Anopheles, I would say, fly much further. Aedes aegypti tend, sort of the common thought is that they don't fly that far, within a 200-meter radius, approximately. I'm sure there are outliers, but that's sort of the standard.
I have a question.
Yeah.
Is this virus doing anything to the mosquito? Like if the mosquito got infected,
Mm-hmm.
is the mosquito
Yeah.
feeling the same thing or the mosquito feeling bad?
I think that there are some studies coming out showing that it can alter the mosquito behavior. So I don't know enough about it, so I don't want to, but I think there is evidence, people are starting to do investigations now that shows that it can affect the mosquito behavior
Yeah, that would be
and host-seeking behavior and that kind of
Yeah, it maybe change some behavior which
how frequently they feed or
I think they must do
how
something
frequently they
because
rest.
the virus they quickly amplify. They need
Mhm.
nutrition. They need the protein things. It's just like something like for infected people. People will feel quite uncomfortable. And I hope the mosquito also feel uncomfortable. But who knows?
or they might become blood crazed all of a sudden.
Oh
right?
gosh.
I mean, really, they might. I would think the virus would have motivation to make the mosquito want to feed more quickly or more
Maybe.
frequently, bite more,
Oh jeez.
something like that.
Okay.
Okay, so brief. This is a generalization, but some of the factors that have driven the emergence of the epidemic in the Americas. Latin America is the most urbanized place in the world. 77% of people inhabit urban areas. And most of this has happened very quickly over the last few decades with little urban planning, I think as many of you know. As I mentioned before, vector control weakened after dengue was eradicated in most of these areas, and so that has made it really difficult to now reduce the vector because during that time when we stopped doing mosquito control, there was this boom in urban population growth. So the mosquito came back in, and all of a sudden there's like all these people and all these containers, and this sort of perfect habitat for the mosquito. So the high cost of insecticide application, where you basically go door to door to door, the inspectors go house to house, inspect your patio, leave a granular organophosphate larvicide called hemifos, and so it's incredibly labor intensive, and it's a lot of material, a lot of chemicals. It's very costly, and to be able to really go around and visit all these households frequently enough is just totally unsustainable. It's very costly. The other major factor, of course, is travel and trade, which was unprecedented, before air travel, right, in the last few decades. The primary climate drivers, and I'm going to talk more about this in the next slides, are rainfall, but rain or drought, interestingly, can increase mosquito breeding. So it depends on the social conditions, and I'm going to spend quite a bit of time talking about this. Mosquitoes are breeding in containers where people store water. So if you're in an area where people store water because there are drought conditions, you're creating more breeding sites. On the other hand, if your patio looks like this, but maybe you don't need to store water because every time you open the faucet, water comes out, but it rains a lot, then all of a sudden you have more breeding sites in the patio. And so how rain affects dengue depends on the social conditions. Temperature is a little bit more straightforward because it's mosquito physiology, basically, right? So temperature increases, everything in the mosquito develops more rapidly up to a certain point. You can think of sort of standard, curve that govern all biological processes. So when temperature increases up to a certain point, we have increasing biting rates. So the mosquito feeds more frequently. The larvae develop much more rapidly, so the period from egg to adult is much shorter. The extrinsic incubation period is shorter as well. There are also global climate drivers that I keep mentioning. El Niño Southern Oscillation is really important in areas where El Niño affects local climate, and that's different everywhere. So it's hard to generalize, but in the areas that I work in, and I'm going to show you some figures, El Niño Southern Oscillation is a really critical driver of our local climate. And then climate change, question mark. We don't know. It's hard to know. We can come up with predictions, but we don't have long enough time series. And there are all of these other things happening at the same time that I hesitate to say that the epidemics are being caused by climate change, but certainly we're creating conditions for, that in the future, that we're creating conditions that are more apt for continuation, spreading into new areas, increasing distribution, and changing the cycles, the seasonal cycles also. So as I mentioned, El Niño is really important in the area where I work in southern coastal Ecuador. This is the Pacific coast of South America. This is a figure that shows the correlation between sea surface temperature and rainfall. And there's a lag, right? So sea surface temperature, the oceanic El Niño index in October, November, December, and rainfall 3 months later. Is that 3 months? November? A few months later. Basically, there's a lag, and it's referred to as teleconnections. So what happens in the ocean several months later can affect what's happening in the local climate, for example, offshore Ecuador. And if you follow anything with El Niño, you know that sort of northern Peru and southern Ecuador is one of the zones that is always most affected. If you see images of flooding and sort of disaster, that's usually this region. So when El Niño events happen, we have lots of rainfall and temperatures increase also. And this year, right now, I think the last predictions I saw at the end of July said that we're about 80% probability of going into an El Niño year this fall, beginning this fall. Just to mention, some of my close colleagues in Ecuador have been working to improve the forecast of rainfall in this region, and they've been able to use this kind of information to improve our local predictions of rainfall, which is important for predicting disease. And so then the question is, if we have some idea that yes, El Niño is linked to local climate, the question is then, is there a linkage to dengue? And so I worked with Rachel Lowe, who is a wonderful statistician at IC3 in Barcelona, a climate research institute, to look at dengue transmission in El Oro province, which is the province of where Machala is, from 1995 to 2010. And these are anomalies in incidence, monthly anomalies. And what you can see here is that in 2010 we had the biggest epidemic on record. And these local climates, so the blue are precipitation, rainfall, and the red is mean temperature, and above and below there are dashed lines for min and max temperature. Also anomalies, monthly anomalies. And so that's the ONI, the sea surface temperature anomaly. So the red on top, when it's red, it's warm, it's El Nino events, when the ocean is warming. And when it's blue, it's cooler, that's La Nina events. And so the question is, can we tease apart the seasonal cycles to determine whether El Nino and local climate are really triggering epidemics? So interannual variability. We don't just want to know, is there a seasonal cycle, but we want to know, when there's greater than average, or stronger than average El Nino, are we actually going to see more dengue than average?
Can I ask you a quick question?
Sure.
Are those anomalies compared to the 15-year mean, or anomalies compared to the average for that month over 15 years?
Yes. So,
The second one or the-
January, the average, so an anomaly from the average January.
Is the January anomaly?
Correct. Yeah.
May I have a question?
Yes.
How can the precipitation be minus?
It's the anomaly from so it's the difference from the mean in that given month.
Oh, okay.
So it's above or below average rainfall, you could think.
Oh, okay.
So
Thank you.
this is the really, really strong 1998 El Nino event, which is one of the strongest El
okay.
Ninos, right, in the last century. You can see here really high sea surface temperatures, tremendous amounts of rainfall. It devastated the country, massive flooding, outbreaks of cholera, dengue, malaria. I mean, it was really nasty.
Okay,
So,
thank you.
just
I thought it just the
Sure.
precipitation, how can it be minus? So thank you.
So yeah, this is a long period where we had much drier than average.
Oh, okay,
Yeah.
got it, thank you.
Mhm. So we looked at all these different parameters and identified which were the most significant lags to test in the model, sort of using bivariate relationships first. And importantly, which most other models don't do, we also looked at non-climate information. So we included information on the number of virus serotypes co-circulating in the country and vector abundance, an indicator called the house index, which is the proportion of households positive for the mosquito larvae. And Rachel, who is a wonderful statistician, worked with me to develop a generalized linear mixed model to test two different time series because we didn't have, I'm trying to remember, we didn't have all the data for both time series. I think, yeah, well, I can't remember which right now off the top of my head, but 2 time series. And we found that yes, we could sort of tease apart what were the climate effects versus the non-climate effects and the combined effects when we put it all together. And yes, El Nino does affect dengue. That's the take-home point. So if we look here, this is the base, is the seasonal model. So just looking at this pattern, right? And how much the variability can we predict from the seasonal model? Quite a bit, right? 44% over here. And then if we add just the climate variables, which were minimum temperature, rainfall, and ENSO on top of that, we get 49%, so we get a small bump. We take the climate out, we put the non-climate variables in, we get more, right, 56. We put them both in, we get sort of an additive up to 61, right, 0.61. And then if we add in the non-climate, the random effects, then we get another bump, which suggests that there are things, processes happening that we have not captured with our model. So we can then go in and look at those plots and say, oh, there was a really strong random effect in these years, and we can start to see, oh, was there a change in intervention or that kind of thing. But this is sort of what we're interested in terms of, is it viable? Is it possible to create a predictive model using climate information? And through the study, I think we were able to say yes for this region.
Just a quick stats question. So
Sure.
I see, it looks like an AIC table, but you've got DIC. What's DIC?
Another AIC measure. I couldn't tell you right now off the top of my
Okay.
head. I'd be happy to pull up the paper
I'm just
afterwards.
curious. First time I've seen
Yeah,
that.
this is where my limits of my statistical knowledge come in. It's another type of Bayesian, similar. These are the model outputs. So on the left is observed versus predicted from that time series. And this is just the 2001 to 2010 best fit model. And you can see here the time series of the black line is observed data, and then the gray bars are the predicted information. And it's a bit difficult to tease apart here, but we plotted it. You can see the difference with or without climate information. So, and Rachel is a really great at this, and she, I was going to pull up the reference, but I didn't find it. Her work was profiled in The Lancet just a few months ago, and it was picked up in the BBC because she did projections for dengue during the World Cup just a few months ago. So she and I are working right now to update this model and do projections for the coming year, given that we're going into an El Nino year. So hopefully we'll have more to come. So I worked with one of my other collaborators, Angel Munoz, who's also a climate researcher, to try to tease apart multi-year cycles of dengue and climate. So other studies from other countries have shown that you see maybe these 2 to 3 year to 4 year cycles of transmission. And some of that, we're not sure exactly. Some of it's climate driven, some of it could be related to immunity, changing immunity in the population. But what Angel was able to show by looking at dengue and rainfall is that in this region, we find these biannual cycles of rainfall and dengue. So it's difficult to see, but on the left it says period. And so it's the period of time, and the bottom number is 2, and the next one is 1. So here, where it says 1, that indicates an annual cycle. So strong correlation between dengue and minimum temperature at the annual cycle. And here, there's strong correlation at the 2-year cycle. And Angel thinks that there may be some other climate forcings happening in the regions associated with perhaps climate patterns that are coming from the Andean side, so apart from just the El Nino Southern Oscillation. So it's something that we're exploring right now. So we have this, we have this sort of basic idea that yes, dengue drives, or that climate drives dengue, but then we wanted to do some local level work to try to understand what's happening on the ground, right? To understand some of the mechanisms for how climate's affecting the disease dynamics. So we did this study in collaboration with the Ministry of Health and the National Met Institute back in 2010, 2011. And we worked in 2 areas, 1 year after the biggest epidemic that I mentioned. So these are 2 areas that were most affected by the epidemic. A central area and a peripheral area in the city. And this is actually very close, like less than a half kilometer apart. But the conditions in the 2 neighborhoods were quite different because the peripheral area, for those who have been to these cities in developing countries, you know that in the periphery, they were sort of most recently settled. These were often households that didn't have legal land tenure, so houses made of bamboo, that sort of thing, mixed with block. In the central area, they had much better infrastructure. They had paved streets, that sort of thing. I used booby traps in 80 households and went every week to inspect the OB traps. And the OB traps give us an indirect indication of the adult vector abundance. And we also did container surveys or mosquito pupae surveys in the households. So we would go to these same households before, during, and after the rainy season to see where the mosquitoes were breeding and which were the most productive containers. So where do you find the most number of mosquito emerging? And we did surveys also with the heads of the households.
You can just see the larvae by eye?
Mm-hmm.
You just know that.
Yeah, and some of it's training your eye, right? Of course, but actually with these, with the pupae surveys, to the best of our ability, we would empty every single container where there was they suspected all that there could be something, and we'd run it through, or just like empty it over a piece of cloth that had like holes, and then we'd resuspend that just to double check. But yeah, so it's very labor intensive. So the interesting result from this was that the climate predictors, the lag climate predictors, varied by site. Well, I'll get to that second. First, to point out that rainfall and minimum temperature were the most important indicators, which was really good news because those were the same indicators we found when we looked at the 15-year time series of dengue data. So we're finding at a very local scale, the same most important climate drivers affecting mosquito abundance were the same as the ones affecting dengue. That's really good. But interestingly, when we compare the 2 sites, we're finding that there are differences between the effects of rainfall. So rainfall and minimum temperature were both important in the central area that I mentioned as sort of little more urban infrastructure. In the peripheral area, only minimum temperature was important. So why? Well, if we start digging into the data a bit more, we saw that where the mosquitoes were breeding, the most productive containers varied by site also. So on the left, where it says CA, that's the central area. You can see data from before, during, and after the rainy season. But what's most important is that you notice the black bars, there's mostly black bars. Those are abandoned containers. So remember before I said if you have your patio full of discarded rubbish containers, then during the rainy season, they're going to fill up with water, and those become the mosquito breeding sites. In the peripheral area, most of the mosquitoes were coming from domestic use containers. I call domestic use containers water storage containers primarily, containers that people were using every day, emptying, or that they had around the household as containers that people self-identified as, yes, we're using these for X purpose, So there were differences in where the mosquitoes were breeding, and that affected how climate affected, how the climate influenced the mosquito abundance.
So why, I'm sorry, so why do you have more abundant container in the central area?
Why do you have more abundant container central area? That's a very good question. And I didn't show the data here, but we had higher mosquito indices in the central area. They have bigger yards, more junk. People in those areas don't think that it's a priority. When I did focus groups with community members, they said, no, our community is beautiful. Why would we have mosquitoes here? Dengue is for the poor people.
But
So,
and what you're showing anyway, it could be, what you're showing doesn't even tell you how many abandoned ones there are in the rural areas, just tells you there are more in the periphery, there's just more
It's
domestic
more,
use ones.
but yeah,
So
there
if you don't
actually
have
were
running
more
water,
of those,
then you
yeah.
have more, or you have less reliable running water.
yeah, one of the hypotheses is that maybe in the peripheral area where people are storing water, and that's the primary mosquito breeding sites, those containers are emptied frequently. You know, people are emptying them every day, every 2 days.
Okay.
And so you might end up with less overall mosquito abundance during certain times of year as compared to a site where there's just stuff filled with water that people are sort of not as aware of. But that was a very interesting finding, yeah. And when you talk to people, then their perceptions of risk are very different than what you're actually seeing on the ground. And these are, there were a few studies that came out this last year comparing, doing massive surveys in 5 countries in Latin America and in Asia, and they published just the vector indices. These sites had much higher vector indices than any of those other sites. So it's a very, very high burden, high risk area. Yeah.
What are the reservoirs for dengue besides human?
So from a public health perspective, nothing. No,
No.
that's the standard sort of answer. But our group has a lot of interest in starting to look for other reservoirs, sylvatic reservoirs, because there hasn't been enough attention paid to them. Sort of classically, you have primates that are reservoirs, and there have been
Right.
some documented studies showing transmission from primates to humans even recently. There was a big splash this last year that supposedly there's a dengue 5, the 5th dengue serotype that was discovered because of primate to human transmission. But there haven't been enough good studies, I'll say that.
So if they are primate, wouldn't it affect the people on the outer
In the
parts of
periphery,
this
yes.
more?
Yeah.
Which is why the people in the center
We
do
were reading
not.
our grant applications last year. Yeah, no, that thing's this peripheral area and this sort of urban to rural interface is a very interesting area to start studying diseases like dengue that people have assumed to be sort of urban, non-zoonotic diseases. But we know that the mosquitoes are feeding on animals, and there's no reason why there can't be movement back and forth. So it's a very, very good question. So one of the other findings was that the risk factors, the characteristics of the households, and this makes sense based on what we talked about, the actual characteristics of the households varied depending on the season. So during the rainy season, households that were most at risk, so most likely to have the mosquito breeding around the house, were households with bad patio condition or bad house condition. They were households that stored water, but that had poor knowledge of where the mosquito were breeding. During the post-rainy or dry season, access to piped water, so lack of access to piped water, constant interruptions in the water supply were a risk factor, as were families that shared their household with other families. So multi-family households were at greater risk. And water storage was one of the factors that was important during the pre and post-rainy season. So we wanted to also look at how these risk factors vary spatially, and if some of the same risk factors, if we could find the same risk factors if we used totally different methods, and we looked at spatial distribution during the 2010 epidemic. So we mapped around 2,000 cases of dengue, and we had to create these maps from scratch, and maps of the neighborhood didn't exist before we made them, so tedious work, but it's been quite useful. So we mapped the dengue cases for the city and used some basic spatial statistics to look for clustering. And this area is where the study sites were that we were working in. And then I pulled out 20 different census variables from the 2010 census based on our knowledge of dengue risk factors. And these variables accounted for population density, demographics, housing conditions. These were other variables not from the census, Aedes aegypti indices and distance to the hospital. And we were able to see that some of the same variables came out, including lack of access to piped water and housing condition. But it was interesting because it was households that did have piped water but that had poor housing conditions. So it was a similar combination of of at-risk characteristics. Households that were older were also more at risk, and women, neighborhoods that had a greater proportion of households headed by women were more at risk. Neighborhoods closer to the hospital were also at greater risk, so it was more of a
Were neighbors closer to the hospital, right?
closer, yes.
And was that like a better part of town, or worse part, or what kind of, where was the hospital located relative to that?
So the hospital is kind of in the center of the city, so it's an indicator sort of, is it central or peripheral? And if you see here, the clustering is sort of central, you're not seeing cases on the far extremes. So it could be because that's where the disease, the epidemic started, and these are actually more at-risk neighborhoods. It could also be because we have poor reporting outside, so it could be an indicator of that kind of bias.
Can you say where the dengue, that's the first time I noticed you had actual incidents of dengue. So where did those data come from? Do you have household level?
The Ministry of Health epidemiological reports. So we have every single person, and then we have their address, where they live, and then we go in and look at their neighborhood and match it up. And we had to use some, what's it? There's a free sort of add-on tool. It's called Geospatial Modeling Environment, because the census data, the polygons are totally different than the neighborhood, and so we had to like go in and basically estimate neighborhood level population, all of the parameters. We had to go in and re-estimate for the neighborhoods. It was a bit
So
tricky,
you have
but
the home address of every dengue patient.
approximately,
That
right?
declared
Or cross
themselves.
streets, enough to be able to identify a neighborhood, yeah.
Okay.
Could you go back to the one Josh asked about? And is it possible that the hospital is a place where mosquitoes feed on dengue patients and fly around the neighborhood?
Could be, yeah, could be,
All right.
as an actual focal point,
Yeah.
source of transmission.
Yeah. And do you have any hypothesis about female-headed households?
Yes. So I've been working on finishing up another manuscript I'm in the revisions right now. And so I did focus groups with these same communities. And one of the themes that came out is that there's economic difficulties, challenges to that dengue control. And this is much harder for women who work, because women tend to be in charge of the health of the family and vector control in the family. And so if you have a woman who's working, it's much more difficult for her to do all of that and work and provide for the family. So that's one hypothesis. So with sort of all of these previous studies, we can start to construct what we think might represent, at least for this area, a social-ecological system for dengue. And we haven't yet talked about any of the immunology components, so that's really important to mention that the virus and the immunology is a critical part, and that's some of the data we're gathering now is going to allow us to understand that more thoroughly. But we can start to understand that we have ENSO affecting local climate, there's different things happening in the different seasons, different water sources or container types that are the primary containers driving transmission. This is thinking at the macro level, not at the neighborhood level, not maybe at the city level. And this influences, the abundance of these chip diet. We have different risk factors in each season that are determining dengue risk. So this is where I was mentioning I did some studies to look at community perceptions of dengue. And this is really important, even in the context of early warning systems, because if you have an early warning system, presumably you want the population to do something, right? You're not, the Ministry of Health needs the population to empty their containers or go to the clinic when they're sick. And so understanding the local context and what people perceive, the risk factors, what they perceive to be the barriers or their role in the community in dengue control is important. So this is an example of one of the concept maps that I worked on with one of the communities. So we asked them to talk about the causes of dengue in their community and the impacts. And so, for example, they said here, they're talking about the mosquito. They said, okay, what are the causes of the mosquito? Well, we have accumulated water, garbage, dirtiness, vegetation. Said, okay, well, what are the causes of the garbage and dirtiness? They said, the neighborhood, our neighbors, they throw their garbage out at a different hour, different day when they're not supposed to. Okay, so why? Why do they do that? He said, because they're lazy. And then the dogs come, and then they open the bags, and then the garbage collectors won't pick up the garbage that falls on the streets. So you can kind of imagine this sort of narrative is what we were able to pull out of these conversations. Really interesting. So I analyzed that information and coded it to look at what were the most frequently mentioned factors, risk factors for dengue in these communities. So the three main groupings that we came up with are the biophysical risk factors, political institutional factors, and community household factors. And one thing I want to point out is that under political institutional factors, we have things like access to garbage collection, access to piped water, the need to strengthen regulations and policy, access to vector control, urban planning. Access to garbage collection and potable water, sewage, those are things that represent sort of the overall needs. You know, these are very broad sort of infrastructure and development needs. And so when you ask the community about dengue, they're going to talk, you know, they frame dengue in this broader context of what they need for urban development. And interestingly also, those are things that the Ministry of Health doesn't deal with. So those are things that the municipal government deals with. And so this really points to the need for interinstitutional coordination. This is very much, you know, an issue that spans multiple institutions. The other thing to point out is that the ones that are italicized are themes that came up only in the periphery. And so in the periphery, they identified many more political, institutional, and community household themes. And they were more linked to economic factors. Social cohesion was an interesting theme that came up, and I'll talk a little bit about that. And then access to urban planning, political access, the fact that they felt marginalized, you know, they saw that as directly influencing their risk and exposure to dengue. So some of the economic factors, just briefly, these are quotes from the focus groups, and the first woman says, I think these were women, I think that everything is clear because each of us, we have to just be aware that our house has to be clean and cared for and then we won't have dengue. Then the next person says, yes, because cleanliness is something that does not have a cost, it only requires the willingness of the person to do it. And then in another focus group, they said, well, I think actually the difficulty many times is the economic situation, that we don't have the resources to buy a mosquito net. Many times we're extremely poor. We don't have any way to protect ourselves from a mosquito. This is a serious cause of dengue in these areas, in the peripheral areas, the areas that are poorest in the city. One of the other interesting themes that came up was the lack of social cohesion and how that, they saw that as really one of the key factors influencing their ability to mobilize and to take prevention actions. So they said here, what is missing is the union of the people. Because if we're not united, we can't achieve any objective. And they said, because they always say to be united is to have strength. But then they go on to say, but we always need this with the support and coordination of the Ministry of Health and the municipal government, because if we do it by ourselves, no one will pay attention. So we'll do our part, we're not going to wait for you to come, but you need to help us also. So they're indicating, up until, in this area especially, there has been almost no engagement of the community in the vector control program. It's largely been a top-down model, as it has been pretty much everywhere in the world. And there has also been limited coordination between the government institutions, and so the community members are pointing out, you know, quite clearly that this is something that they see as a risk factor for them. Okay, so based on that previous experience, we've been working with the Ministry of Health and the National Met Institute to develop an integrated surveillance system here in the city where we're gathering information on climate, which are the yellow triangles, on the dengue virus. So we're doing surveillance in the hospitals and we're doing active surveillance out in the community, and we're gathering information on the vector. So this is an example of the red points could be dengue cases, and then the blue around would be the households that we're visiting around to find out if there are other cases around that index patient. And just to give you an idea, it's a small city, the area, the distance across is about 5 kilometers. And so we're able to get quite a bit of very fine microclimate information, and we're working right now, Angel and I are working to create climate surfaces and to see whether or not there is microclimate variability that affects transmission patterns in the city.
Are you going to look into the percent of vectors that are actually infected with disease at all?
Yes, we're doing that right now. It's pretty cool. PCRing, mashing up little mosquitoes, putting them in pools, and seeing if they have the virus. Yep. So other thing to mention, as I said before, I don't want to miss this, is that for us and for me, training is a hugely important part of what we do. It's a critical part of strengthening capacity. If you want to have an early warning system or any kind of effective surveillance system, you have to invest in strengthening capacity. And that doesn't mean just infrastructure, but in people. And so we are constantly doing trainings and workshops. And these are photos from recent trainings we're doing in the Galapagos, which is a fun place to do dengue work. It's beautiful, and they also have a tremendous need for training and surveillance throughout the islands for dengue and Aedes aegypti, because dengue came into the islands in 2002 and has spread and become established since then. So we've done workshops on geospatial modeling, on bioethics and research integrity, and different surveillance tools. we're working in a central hospital to set up a virology and diagnostic laboratory. And so when a patient comes in to the hospital with clinical diagnosis of dengue, they're sent to us. We recruit them into the study, so we consent them, we do clinical surveys, and we draw blood. And we are running a whole different range of different dengue diagnostic tests to compare its sensitivity and specificity. And we're also running a bunch of different micronutrient assays to look at the interactions between nutritional status and dengue severity. And if the patient comes up positive, then we go out into the field and we do a cluster investigation. So we go to the index patient, the red one in the center, and we recruit anyone in the household who's willing to enter the study. Doesn't matter if they have symptoms or not. And we draw blood from those people, and we do clinical surveys and household surveys, and we collect mosquitoes. And then right now we are pooling and matching with mosquitoes to look for the virus as well. So what's really interesting from this study is we're just right now analyzing the data from the first year, but we see a tremendous number of asymptomatic cases. So people who are likely infectious but have no symptoms, or especially are not febrile. And during the peak of the outbreak this year, which was a late outbreak in June, July, when we would go out into the field, we would find 10 to 20% of people were positive. That's a tremendous number of people. You know, sort of basically, you know, not random, but we're sampling anyone who will be in the study. There's people who are totally healthy, and 10 to 20% are positive, and a large number of those are asymptomatic.
But you're sampling around a known case.
We are sampling around a
It's not random in that
it's not
sense.
random, but it gives you an idea that for every patient who comes into the hospital, there are likely this many other patients, at least within a radius, who are positive. Yeah. So these are just some images of the vector mosquito collection. These packs, which are really great, lightweight mosquito backpack aspirators. So just to bring it full circle, I'm going to wrap up. We've been talking about strengthening disease surveillance, mosquito surveillance. So using packs, it's the first time that in this area they've used adult collections, and so we're evaluating whether that's a more effective, more sensitive way to detect vector abundance. And I think from our preliminary data, we're finding a large number of the pools are actually positive for the virus. So it might be a more sensitive surveillance tool. We are working with the National Met Institute to look at climate monitoring to set up this microclimate surveillance system. And some of the previous work we've done has shown that there are indeed linkages between climate and dengue, and that these linkages are moderated by the local socioeconomic conditions and ecological conditions. So, all that being said, probably the most important factor, with a tremendous amount of uncertainty and who knows about the response time, is the institutional factors and getting conversation going and getting everyone on board, getting the Ministry of Health and the National Met Institute and the municipal governments to sit down and talk to each other and to sort of start thinking about this in a different way. And that's a lot of the work that we've been doing is, I mean, it's door knocking, right? Talking to people, just constantly kind of talking, and getting people to sit down together and say, yes, climate and health, this is something that we should be talking about and dealing with and thinking differently about how we make decisions and how we structure our data systems. You know, what are the data flows that are coming together? So that's really one of the biggest challenges, and not just here, I'm sure it's anywhere. And there's a lot, like I said, a lot of uncertainty because we're working with institutions that change. You know, if you have the leader who is very pro climate health and then someone else comes in, and it changes the whole dynamic. So incredibly important. I want to recognize all of the members of our team, the different institutions that we work with in the US and in Ecuador. So we have, as I mentioned, a pretty large field team. We have Americans and Ecuadorians working on our field team. I'm very lucky. We have really great collaborators, and you know, I've been doing work in Machala specifically since 2010, and we go back again and again because our partners there are just incredible, and we wouldn't do it otherwise. So thank you.
Sorry, question. When you were talking about the climate effects on your ability to predict dengue, and it was like a 6% or something by adding climate.
The added, yes.
I was just wondering what that 6% actually means to someone who's trying to decide what resources to allocate to dengue. Because it seems like I don't know, I would just be curious
Is
what
it not
moving
enough?
from 44 to 49% certainty does in the people
In
you're
the
working
decision-makers'
with
mind?
mentality, yeah.
That's a good question. I'd have to ask them. Well,
I'm just curious.
I couldn't give you a good answer. I think if you go and you say to them, look, there's a 50% probability that there will be an epidemic this year, is that enough to make them
Mhm.
change their behavior?
Yeah, as opposed to 44, which is still pretty high, or.
It's actually the difference between 56 and 61, right? Because you'll always know the non-climate effects. Question is,
We don't though, no, because the non-climate data, they're really weak vectors.
She just asked about climate data.
Yeah, but the non-climate data, we don't have good non-climate data.
But
So
what
like in
difference
terms, that
does
was one of the
climate
big
data
recommendations that came out also, is the need for better information on like what viruses are are circulating in the country, because that's actually quite weak. We have climate stations that are continuously gathering data, like meteorological stations that we have 30 years of time. We are much more limited on the side of virology data. We had to work with data aggregated at the country level, just number of serotypes circulating in the country. So that's the fact that the non-climate information was so important is something that I think is a take home also. I don't know that I have a good answer, but it's a good question. I think at some point so this is basically a model that says yes, there are effects. The
Right.
next step is we have to work to create forecasting, which is a different thing, and it involves doing all sorts of analyses to produce forecasts of actually how good would the predictions be. And that's sort of the next step where we are right now. And depending on how the forecasts are, I think that's something you would then go to the decision makers and say, okay, is this good enough? What do you need? Or what's the range of uncertainty? And at the end of the day, you convert these into alerts, right? So you're not coming to them with a probability or a number. Usually you come to them with like low, medium, high risk, that kind of thing. Yeah.
Yeah, sorry. I have a question. Do you find people, based on the immunology, the situation, do you find people naturally resistant to this
Naturally
disease?
resistant.
They
So
just never get it.
They might get it but not be symptomatic, right? So there are studies that suggest that people with African descent are less symptomatic.
Oh, wow, that's interesting.
So there aren't any great studies yet, but there are some studies and there's some evidence that suggests that people of African descent are less symptomatic. And you're seeing, so for example, there are parts I don't know the countries specifically, but some of my collaborators work in Kenya and Uganda, and they've told me stories that dengue is almost never picked up. People think that there's no dengue in Africa and in these areas that are malaria endemic, because if it's fever, people just assume it's malaria, right? Partially, or because there's so much malaria circulating that maybe it drowns out the dengue signal. But when new populations have immigrated to these areas, like from Middle East or from, they find there's a dengue epidemic all of a sudden, because it was likely circulating in the population, but maybe the people were asymptomatic. These new population comes in, and all of a sudden you're seeing dengue symptoms, like classical dengue symptoms of rash. So there are definitely some differences in genetics that determine how you
I'm thinking about
express
like the
illness.
genetics, affect the immunoprofiles. So maybe some people they just never trouble by that.
Yeah, for sure. And nutritional status also.
Oh yeah,
could
nutrition
potentially
status,
be.
yes.
But there have been very few studies done on nutrition, so we're hopefully going to have some interesting results.
Yeah.
We just had a review come out on nutrition and dengue, so.
Thank you very much.
Other questions?
I just had one question about predicting the trends. It seems like there's things that you would have people do, like dumping out their containers, they would just do all the time. Why is it so important to be able to predict when an epidemic is going to happen, as opposed to just get baseline behavior so that you're always safer?
I think there are sort of there's like no risk interventions that should be baseline behavior. But at some point you have to scale up probably and invest more in dengue diagnostics. Diagnostics are super expensive, right? Pesticides, diagnostics, start to scale up maybe education campaigns to mobilize the population. Most of this work happens through people going door to door. So that's also incredibly resource intensive. Training doctors, like if I knew that it was going to be a big dengue year, you would hope that you do trainings all the time, but then you would just try to scale up, I guess, so that they're properly diagnosing. you kind of get everybody on alert also that this is sort of the whole public health sector starts to kind of be more wary and detect cases more quickly. That's the hope. But there are definitely baseline behaviors that you want to have ongoing all the time. It's hard. It's hard to get people to change their behavior and to do things when clearly they have many, many, many other priorities, right? Especially if they think that their neighborhood isn't at risk. So, yeah.
So you might have mentioned this, but I'm just trying, is there a difference in incidence in between the central areas and the periphery?
So that's
Within like actually symptomatic, like have, you know, not within the mosquitoes, but within the population.
That's a very good question. So we only have that 1 year that we georeference for 2010, that's the only 1 year of georeference data we have.
Okay.
So anecdotally, you can say, yeah, if you go and ask someone, say, yes, these areas tend to be more at risk. So I don't have a good answer right now. With the study we're doing now, hopefully we're getting now some more fine scale information about the spatial distribution.
Mm-hmm.
It depends on the city too, because we did the exact same analysis for Guayaquil for an epidemic in 2012, and that was more concentrated in the periphery. The city's very different, it's a very big city. Machala is a small city, so there's a lot of mixing, so you can get quickly from one part to the other. That change, like in Guayaquil, it's a huge city, so it's unlikely that you're going to have that same amount of mixing, and so you could have more isolated pockets of outbreak.
Yeah.
But this is one of the biggest difficulties is that most epi information is not georeferenced. So it's like, you know, a lot of work to just map 2,000 dengue cases.
Yeah.
We're starting to do it, but cool. I'll come back with more. Thanks.
Thank you very
Thank you very much.